continuing from the last video, that hypokalemia assessment that is less than 3.5, then we went ahead with assessing the urinary spot potassium levels. We understood that the aim to assess the urinary spot potassium levels to assess the intactness of the tubules in the kidney. So if the tubules of the kidneys are completely intact, then the potassium is efficiently reabsorbed from the tubules. Then urinary levels of potassium will be less than milliequivalents per liter. So here we concluded that kidneys are completely normal. So in this case, the reason for the hypokalemia is transcellular shift. In that, four important diagnoses are there. One is use of excessive amounts of beta blockers or side effect of beta agonist, then alpha blockers and insulin levels. There are many causes are there. So these three are the important with respect to multiple choice questions. Next one is urinary spot potassium levels more than 15 milliequivalents per liter. So here it indicated that kidneys are unable to reabsorb efficiently enough amount of potassium. So urine is throwing out the potassium, leading to hypokalemia. So in this case, next we did ABG, that is arterial blood gas analysis. In that there are two spectrums, that is acidosis and alkalosis. So acidosis, if the acidosis is shown in the ABG, then the diagnosis becomes RTA, that is renal tubular acidosis. So in this, if the proximal segment is damaged and distal segment is intact, then that becomes RTA type 2, where the pathology lies in the PCT, hence leading to hypokalemia situation. The next one is the distal segment is the pathology lies in distal segment and proximal segment is completely normal. In this, it is known as RTA type 1. If the ABG shows alkalosis pattern, then the next step is assessment of the blood pressure. If the blood pressure is low to normal, then we came to conclusion that there are two important differential diagnoses here. First one is Barter Syndrome, next one is Gentleman Syndrome. Next, if the blood pressure is high, then the diagnosis becomes three important spectrum, that is Liddle syndrome, Cushing syndrome and Cone syndrome. Here, the point to remember is all these three come with typical triad of clinical features. What are these? Hypertension with metabolic acidosis with hypokalemia. So with this basic understanding, we'll try to move forward. That is hypokalemia. First we did, and then we did urinary spot potassium. After the assessment of urinary spot potassium, if the urinary spot potassium is high, then we concluded that the kidney is the problem. Then we did ABG. After the ABG, we classified as acidosis and alkalosis. In the acidosis, the diagnosis becomes RTA, that is renal tubular acidosis. So renal tubular acidosis, there are four important causes, four important types are there. The RTA type 1, RTA type 2 are important with respect to hypokalemia, because both in RTA type 1 and RTA type 2, hypokalemia is seen, whereas in RTA type 4, it is a hyperkalemia situation. And how to differentiate between RTA type? So this is a spectrum of acidosis plus hypokalemia. So hypokalemia plus acidosis, the diagnosis is renal tubular acidosis. Again, it is two important types, RTA type 1 and RTA type 2. RTA type 2 is proximal segment is the problem, that is pathology lies in PCT, and RTA type 2 pathology lies in distal segment, that is skeletal duct, there is a problem. How to differentiate between these two important things? So if the PCT there is a damage, then as you know that proximal segment is the reason for effective reabsorption of almost 99% of the glucose, amino acids and phosphate. So here the PCT is damaged, that is glucose, amino acids are not at all absorbed, they are thrown out excessively leading to glycosuria and amino aciduria, and very important point is phosphaturia, because phosphate is efficiently reabsorbed only in PCT. So if the question says that phosphaturia is present, then most of the time the diagnosis becomes RTA type 2, because phosphaturia is absorbed completely and efficiently only in PCT. So if these three things are there, then the diagnosis becomes PCT type 2. Then the point to be noted here is the magnesium levels are normal here. the magnesium levels are normal here. Why it is important to know? Why? Because if the magnesium levels are low, that is hypomagnesemia, then the diagnosis becomes RTA type 1. Because in RTA type 1, distal segment, there is a problem. So how to differentiate between these two things? First one, so distal segment, there is a problem. Here, point to be noted is hypercalcemia is seen here. Hypercalcemia is seen here. Why? Because calcium is calcium is also not reabsorbed efficiently, and this the calcium metabolism, its reabsorptive capacity also there is a problem leading to hypercalcemia. So this hypercalcemia again leads to a very important spectrum that is known as kidney stones and its lesions. So hypercalcemia, hypomagnesemia, and presence of stones points towards RTA type 1, that is distal segment pathology. And one more point to remember here is, since hypercalcemia is there, hypercalcemia is always associated with dehydration, or fluid loss, dehydration or fluid loss. So why it is important to know? Because in this state of hypercalcemia, presence of stones and dehydration, the angiotensin, that is RAS system, is excessively active here. The RAS system is excessively active here. When RAS system is excessively active, even the aldosterone activity is also increased. Aldosterone activity is also increased. Why it is important to know? Why? Because even when this spectrum, that is dehydration, RAS activity and aldosterone activity is increased, again it leads to throwing out of what all the potassium that is remained. This dehydration status and hyperaldosterone status again throws out excessive amounts of potassium. So again there is a hypokalemia situation. So if the patient, if the question in the MCQ says about presence of stones or presence of dehydration and hypomagnesemia, the diagnosis is pointed towards RTA type 1. And if the question says that there is a presence of phosphaturia, amino acid urea and glycosuria, the diagnosis becomes RTA type 2. And RTA type 2, that is PCT damage, is again vast majority of causes are present. So important are, there are 4 to 5 very important causes are there. First one is Fanconi syndrome. Which defect or which causes pathology in the PCT. Next one is, there are many mineral toxicities. What are these? Important is lead. Next one is cadmium, which also causes ouch disease. Next one, mercury, that is glass blowers disease. So lead, cadmium, mercury, Fanconi syndrome. And there are many drugs also which will affect this. One important is acetazolamide. So these are very important causes which lead to RTA type 2. Then what is the important cause for RTA type 2? Here point to remember is amphotericin B. So amphotericin B is very important drug which will cause RTA type 1. So there are many important causes of RTA type 1 and type 2 are there. You'll understand in next slide. So this much is very important and brief explanation regarding RTA and differentiating RTA with respect to MCQs. Next one, that is clinical spectrum of hypokalemia and alkalosis. Because here it is acidosis. So in this, what we did is, we checked the blood pressure, and blood pressure was high in few cases, and blood pressure was low to normal in few cases. We came to know that if the blood pressure is high, it becomes a spectrum, that is hypertension, metabolic alkalosis, and what? Hypokalemia. So I told that 3 important differential diagnoses here. One is Liddle syndrome, next one is Conn's syndrome, next one is Cushing syndrome. The 2 important are there. One is known as GRE, that's not important. So the 3 important differential diagnoses here are Liddle syndrome, Conn's syndrome, and Cushing syndrome. And how to differentiate between them? The important note here is Liddle syndrome, the word itself says everything. So there are 2 L's here. two L's. What one L will stand for? One L stands for low aldosterone levels here. Next one is low renin level. So low renin means what? It is one of the example for hyporeninemic hypertension. There is a hypertension, but the renin level is low. So low aldosterone, low renin levels. Next one is dominant inheritance, autosomal dominant inheritance. Next point to know here is also there is a low potassium, that is hypokalemia, low potassium. And here patient comes with actually secondary hypertension or resistant hypertension, and the drug to be used here is amiloride, which is actually ENaC channel inhibitor. And next, how to differentiate between Conn syndrome and Little syndrome. What is Conn syndrome? As you know, Conn syndrome is primary hyperaldosteronism status. So here the aldosterone levels is far higher than normal, more than 1 nanogram per deciliter. But here the renin levels is again low. So low renin levels do not differentiate between these two. To differentiate between Liddle and Conn's, we should check for the aldosterone level status. If the aldosterone is high, the diagnosis goes towards Conn syndrome. If the aldosterone level is low, the diagnosis goes towards Liddle syndrome. And Conn syndrome, the drug of choice to be used here is spironolactone, because it is one of the efficient drug which will inhibit the excessive activity of aldosterone status in the body. Next one is Cushing syndrome. Cushing syndrome, differentiating here again here becomes one of the important criteria. Why? Because Cushing syndrome comes with spectrum of diseases, which we'll understand in future videos. Next one. What if the blood pressure is low to normal? I told you that in this case there are two important differential diagnoses here. One is Barter syndrome. Next one is Gentleman syndrome. And how to differentiate between these two things. So Gentleman syndrome, we should remember one important point, that is man. So Barter syndrome we can remember with one non-formal way to remember. If you go to bar, what happens? Your stress reduces after intake of alcohol. That is, tension in the mind decreases. Nothing but low blood pressure. You can remember like that. So here one is low blood pressure. Next, in gentleman, again we can remember like that. Gentleman, there is L behind man. That is a lazy man. You can remember that lazy man don't take any tension at all. So the stress levels in the lazy man is very low. So in gentleman syndrome, again the blood pressure is low. We can remember like that. One more point to remember is, you can remember with the yum here. What is that yum? If the magnesium levels is low, then the diagnosis becomes gentleman syndrome. And if the magnesium levels is normal, then the diagnosis becomes Barter syndrome. Here magnesium levels is unaffected. So if the question says that the patient is also suffering from hypomagnesemia, then the diagnosis becomes gentleman syndrome. And if the question says magnesium levels are unaffected or completely normal, then the diagnosis becomes Barter syndrome. And point to be noted here is, Barter syndrome is because of which channel defect? It is sodium, potassium and 2-chloride channel. And what about gentleman syndrome? It is sodium and chloride. So this channel is affected here. So we'll try to understand with detail regarding a differentiate point between all these things in the upcoming videos. Thank you.